Welcome, everyone. My name is Haley Buckner, and I'm the Professional Relations Manager for Elevate Oral Care. Thank you for joining us this evening. Before we start, I'd like to cover a few housekeeping items. For those of you who remain online past 50 minutes, your CE certificate will be emailed within hours of the completion of this talk. Be sure to check your spam folder. You are all muted, so there is no need to worry about background noise. We will have time at the end for your questions, and you can submit questions on your webinar dashboard as they will be tracked throughout the talk. We have hosted an extensive series of free live CE webinars on many prevention topics. Each of these webinars were recorded and are available with free self-instruction CE at the web address elevateoralcare.com/elevatingcare. Bookmark this page and return often to see what's new in free CE. On this link, you will find a previously recorded webinar with Dr. Jeremy Horsekeeper on iodine for caries management. Tonight's course, which will be a continuation of and provide additional information of the previous iodine webinar, so be sure to catch that one on demand if you haven't already. If you have a topic that you would like to see covered, feel free to suggest it by sending an email to info@elevateoralcare.com or by completing the webinar survey that will be sent after the completion of the talk this evening. We enjoy looking through your suggestions and creating webinars based on your requests. Tonight, we are honored to be joined by Dr. Jeremy Horsekeeper as he discusses antimicrobial iodine to complement fluoride in routine oral health care. Jeremy Horsekeeper is a pediatric dentist, biochemist, and educator. Jeremy is known for introducing non-invasive therapies for dental caries throughout the United States. He led the protocols, established the set, and performed some of the primary mechanistic, safety, and efficacy research. Jeremy's advocacy led to guidelines and formal support by the Indian Health Service, American Dental Association, and World Health Organization for this emergent field of oral health care. In support of this work, Jeremy holds affiliations with the University of Washington in the Diabus Dental Therapy Program. Jeremy continues to drive the development and availability of better treatments, preventives, and diagnostics through investment, consulting, and integration into medical and dental reimbursement to improve access to person-centered care, integrate oral health into overall health, and to stop dental caries. Dr. Keeper, thank you so much for joining us tonight, and I'm going to turn it over to you.
Thank you so much, Haley, and thank you so much for having me on this session. Thank you for the viewers who have joined us. It is an honor to share your time. It is an honor to have the trust of your time. I hope we have a lot of engagement through the Q&A. You're welcome to write questions at any time. And of course, we'll take live questions at the end. We did a webinar together, Elevate and myself, a couple of years ago on this topic, almost 2.5, 3 years ago now. And it was well attended, well received. There's been over 6,000 views of it on YouTube. If you don't know, Elevate has a great resource where you can get free CE for watching the webinars that have been viewed before, just answer a few questions. I use it, it's great. But a number of questions have come up since then, especially as they've launched the associated product with povidone-iodine that we're here to address today. So today we'll have a little bit of a review and some new answers to new questions, focusing on how to integrate povidone-iodine into dental practice. So the objectives are that you'll be able to describe the clinical trial evidence for the effect of 10% povidone-iodine on caries prevention, periodontitis, and peri-implantitis. That you'll be able to explain to patients the safety profile of povidone-iodine and screen for contraindications. And finally, that you'll be able to explain to colleagues the anti-caries mechanisms of iodine and the relationship to fluoride. By way of disclosures, I am currently a free agent and don't have formal paid affiliations with any as my primary employment. I'm starting something new and very excited about it. But certainly I used to be employed by large organizations like UCSF, DentaQuest, CareQuest, and have been funded by organizations that are, have my research funded by organizations that are involved in the production and distribution of, I guess just the production of silver diamond fluoride. I've received honorarium from various organizations, distributors, manufacturers in dentistry, including for this course. I am on a few advisory groups of some of the international, national dental products and distributor companies, and I do that both to help um, progress the field, to influence the distributors, manufacturers, leaders of oral health products, services, and insurance to go forward from the past. And I think this talk is a reflection of that. I also have in the past and will again in the future get funding from performing clinical dentistry, and that has very strong biases associated with it. I would say at least as strong as any of the others that I've described thus far, probably stronger. Um, and I don't have any money invested in, and I don't get any money from any specific products. So here's the outline for the rest of our time here today. Shutdowns and medicine cabinets. We'll talk about mechanisms, evidence for perio and caries, as we talked about, caries mechanisms, the relationship with fluoride, safety profile, and then in particular, we'll get into some questions that have already been provided and responses where we've looked up the literature responses already. So, 4, shutdowns and medicine cabinets. In 2020, in February, this is roughly what I looked like and what I was doing. Primarily, I was doing clinical pediatric dentistry and having a lot of fun interacting with families and patients in a vibrant practice. I was doing a little research and teaching, and then obviously COVID hit, and this is what I looked like. So I went from being sort of a full-time worker to a full-time dad. This is the youngest of our 3 kids, all of whom were, I think, under 4 at the time, or maybe the oldest just turned 4. So 0, 2, and 4. And it was a little wonderful, humbling, overwhelming, exciting. And if you know anything about me, if we've interacted before, you know my brain needed some outlet beyond daddy care. And daddy care was wonderful. I learned a lot. But you can imagine my 2 and 4-year-old were throwing things and looking even more crazy than the baby outside of this picture. So what we decided to do was that I would have an hour each day when my wife was no longer on her virtual work, where I could go up into our office and do whatever I wanted. And so one of the things that I thought about was that, in this shutdown, where dentistry was essentially completely shut down except for emergency services, and people were at home eating more sugar than ever, processed foods and packaged foods. What was a simple thing that we could do? What would be the most helpful thing that we could do to control the disease that I've focused my career on, dental caries, the most common disease in humans? What can we do? We've talked about just rinsing with water after you eat. That's something. Brushing, flossing, all those things. But I thought, what's available to everyone that could be beyond what we've been doing? Is there something that we have evidence for, but people just aren't doing, but they actually have right at their fingertips? They actually have right in their medicine cabinet. And this is an AI-generated image, by the way. It's not a real Betatype puddle. Sorry for the brand. But that was what I realized. I realized most people have povidone-iodine in their medicine cabinet already. And this is one of the most potent anti-caries agents that we have. It's not silver diamine fluoride, it's not glass ionomer, it's not a stainless steel crown, it's not an extraction, but it's right there. And if people put it on their own teeth, well, now that's something. So we had a conversation. I called my mentors, my friends, my colleagues, my collaborators, including Elevate, and I said, why aren't people using povidone-iodine? What can we do to get the message out on this? And we did some webinars at the time together, and 1,200 of you attended, and we got some messages out at that time. That was wonderful. But we also talked about, what are the real barriers? And one of the barriers is that people don't think about using it in the mouth. And so I said, what if we made a dental product? And we had some back and forth. And I am pleased to share what I hope you already know, that Elevate actually did create a dental product for oral use of povidone-iodine to overcome the barriers that people have of using a non-dental product in their mouths. And I'm very grateful for this. Again, I have no money in this. I'm just very grateful and interested in promoting it because there's so much science. And that's what we're doing here at Science. We're sharing the science. Now, there's a particular piece here. Now, if you notice on this, on the box, on the picture of the box, it says oral antiseptic. That is no small feat. If you look at the actual indications for use, it says healthcare antiseptic, oral tissues, antiseptic, oral tissues. Now, what do the other bottles say? If you look at the safety data sheet from betadine or other generic products, it says not for oral use, acute toxicity, oral. So the important part here is that that is in reference to chugging povidone-iodine. So if you drink a bunch of povidone-iodine, bad. That's what they're talking about oral use. So you have like oral antibiotic, that means you're swallowing it. This is a this is a point of confusion where the labeling is talking about going through your mouth into your stomach. But what we're talking about here is using it in your mouth on oral tissues, on the teeth. And so these are very different things. And I want to thank Elevate and in particular Steve Pardue and his colleagues for doing the hard work. While I was at CareQuest, I was honored to work with a fantastic group of folks to produce something called the Non-Invasive Caries Therapy Guide. It's an illustrated manual of tips and tricks on how to do these procedures. So while we have many published clinical trials, reviews, systematic reviews, papers about this stuff, as clinicians, we felt that it's very important to actually show how these things are done. And on the top, you can see how this is done with a generic bottle. On the bottom, you can see how this is done with the Elevate applicators. And here is a QR code to go to that. It is freely available. My understanding is that you can get it and print it. And thank you, CareQuest, for supporting that. I think it's really powerful that a big dental insurance company and foundation and so on supports the use of these non-invasive therapies for dental caries. If you note here, we also have myths, or they, I should say, since I'm no longer with CareQuest, they have myths, so it doesn't stain. When it first goes on, you'll see it's brown. Close your mouth, open it again. Stain goes away. There's no shellfish allergy, and there's a myth of bad taste. Does it taste good? No. But if you're just putting it on the teeth, the taste is very subtle. Nothing like our lovely flavor of STF. Anyway, so that was the shutdowns and medicine cabinets. And now we have a dental product that says oral use on it. So hopefully that will hope to overcome barriers that have been there from, over 20 years of clinical trials showing that this stuff helps for caries, and about 70 years of clinical dental research of povidone-iodine in the mouth. So as a review of the mechanisms, we have to understand how this stuff works so that we can share with our patients. What is it? So povidone is a short name for polyvinyl pyrrolidine. Pyrrolidone. I'm joking, but polyvinyl pyrrolidone is PVP is the short name, or just povidone. It's a chemical name, basically saying that this is sort of a resin. It's a polymer that has already been polymerized and has this side chain sticking out. So if you imagine, there's many. It's very long. It's a long strand, and there's these little pieces sticking out, these little groups of pyrrolidone. And on that, what's interesting here is the oxygen sticking out, because that has some polarity, and when you combine polarities, you can have a charge where you share electrons across the nitrogen, oxygen, oxygen, nitrogen, and that can support a proton, a hydrogen ion being hydrogen bonded into place. That then, it turns out, supports an ionic interaction, semi-stabilizing an iodine-3 molecule that has a negative charge to stick around, to stay around, literally to stick around. What this does is that as you add water saliva, really any liquid, you dilute the iodine, and suddenly, because of things that are similar to diffusion, you go from I3 with the negative charge to I2 with no charge. Then there's no association with the pyrrolidone anymore, and the iodine goes free. It goes and kills microbes through a different interaction. So it's this sort of sticky long chain of carbons with this cyclic group sticking out that can bond, ionically bond iodine. It likes to curl up a little bit. It likes to be very sticky, which is helpful for substantivity. Now, in terms of, oh, this was supposed to come out slowly, my bad. Anyway, how does it work? So we're going to do a little review. In our previous webinar, we go into these 5 slides in detail, but just to, as a review, what I just talked about was that saliva activates the release of iodine by diffusion, and that's this panel here, which shows concentration. The higher the concentration is, the less free iodine you have, the more it's actually stuck to the PVP, to the povidone. And as you start to dilute it, it goes out into solution, reaching maximum effect at about like 1 to 5, 1 to 10, 1 to 10 to 1 to 100 fold dilution. And that if you actually look at microbes, microbes grow happily at full concentration, but again, as soon as you dilute it, you get actually the microbes being killed. And so that's what that slide is about, is that you dilute. You have to dilute it if it goes in the mouth. Even if you put it right on the mouth, the saliva will come in and then it activates and kills. And what we see is that functionally in the mouth, you get complete antiseptic action wherever you put it in about 15 seconds. And then how does it actually kill the microbes? Well, it can open up the cell membranes like most broad spectrum antiseptics. But it permanently attaches to the side chain rings of proteins, of DNA, of RNA, therefore also having a long-term effect on the microbes. And it seems to basically just not go through into our skin, into our gingiva, almost at all. So that's fantastic. And then in terms of the anti-caries mechanisms, there was this discovery in the 70s where they saw that iodine differentially kills cariogenic bacteria. So it kills strep mutans at 1/5 of the concentration at which it kills strep sanguis, which just doesn't cause cavities. And it kills it much more quickly, 4 times to 6 times faster than it kills, like other bugs like actinomyces. So it seems to have a differentially potent effect on bacteria that cause caries, kind of like xylitol does, which is very encouraging. Also, if you look at the oral products that are out there for products that are out there for over-the-counter use, it's really the only one that has a powerful effect on glucosal transferase. That's the important enzyme on the surface of strep mutans that really produces plaque. So it produces glucan from sugars, and it has a dramatic effect on that, and that's been well described. Finally, there's this long-term suppression of strep mutans and other bacteria like it, where you put it on once, and Caulfield and Gibbons and other folks over, especially in the 70s and 80s, did a lot of research where they put povidone-iodine, where they took a plaque sample, looked at how many strep mutans were in there, put on povidone-iodine, looked immediately after, looked half an hour after, looked a week after, looked 3 weeks after, 8 weeks after, 12 weeks after, 24 weeks after, and what they saw is that it was really suppressed and it slowly came back. We'll see a chart of that a little bit later, but in terms of the mechanism, it differentially suppresses the bacteria that cause caries, and that seems to be its anti-caries mechanism. We'll go into it a little bit more, but that is the review. Fun stuff. Cool. So now we're going to review the caries, dental caries trial evidence, clinical trial evidence. So I was honored to publish this this chart, and there's some other really great charts in dental clinics of North America. Gosh, 6 years ago now, with Peter Milgram and Jay Tanzer. Jay Tanzer was the person who made this discovery that povidone-iodine, or actually just iodine, differentially suppressed cariogenic bacteria, strep mutans in particular, and did a lot of work on it over the years. He's a fantastic microbiologist and dentist. So we published this, and this is just a summary of the comparative clinical studies. So 2 of these studies are not technically randomized clinical, they're not randomized, but they're comparative clinical trials. And what we saw was this pattern where there were a couple trials that had no effect, no statistically significant effect at their 1-year outcome or 10-month outcome or whatever it was. And there were 5 are listed here. 1 more was added later, I'll show you, that did. And when we looked at it, we looked, okay, what's the follow-up time? What's the form of the povidone-iodine? What's the age at the start? Is it the size of the study, et cetera, location? What really seemed clear is that the duration of the intervention was only within a month in the trials that did not have a statistically significant effect, and that the trials that kept putting povidone-iodine on over time had a big effect. What's a preventive fraction? What that means is that that's the percentage less cavities that you get if you do this. So let's say the control group gets 5 cavities after a year. In this study here, the treatment group would have gotten only 1. So that's quite a large number. We'll dive into that more in a second. But this is interesting, and please check out this paper. There's other things in there, like showing the chlorhexidine trials that unfortunately have no effect, and very importantly, showing the xylitol gum trials in new moms, which has a powerful long-term effect on the caries in the kids. So yeah, check out that paper. Now this is where we took those same clinical trials and another one that was published after we wrote that paper, and performed a forest plot, a meta-analysis of those trials, where we're trying to see, what is the overall effect of these trials across these trials. We combine the effect, where each clinical trial is a tree, and we want to see the forest amongst the trees. And what this chart is this line. If any of the dots overlap that line or are on that line, that means there's no statistically significant effect. That's the line of no difference. So for this group of studies up here, which is less than 1 month of application, this diamond is pretty much right on that line. It means there's no effect. If we look at the 3 trials that had application for 6 months, more than 6 months, then we see a statistically significant effect for 2 of them, and then also for the combination of them. And what this number translates to is a 28% preventive fraction. So 28% less new cavities from this application protocol. And what's common in these 3 studies is that they all have fluoride varnish in the control group and fluoride varnish in the treatment group. They just have povidone-iodine before the fluoride varnish in the treatment group, and that gets 28% less cavities. If you look at the trials that apply povidone-iodine over more than 6 months, you see a much larger effect. Now, these are smaller studies. They happen to be smaller, which is why these whiskers on the dots are much longer. They happen to be in younger children, and they happen to have no fluoride in either group. And what we see here is a 76% preventive fraction. Now, the large width of this diamond means that we're really not certain about the exact number here. Somewhere between 90% and 40% prevented fraction. Either way, it worked really well in these kids. And this one, the whiskers are so long because in the treatment group, these are kids coming out of general anesthesia. None of the kids in the treatment group got new cavities, and all of the kids in the control group got new cavities. 80% of the kids in the control group got new cavities. But if you have no cavities, then the statistics make it so that there's a lot of uncertainty. All that said, overall, if you include all these trials, the ones with less than 1 month, the ones with fluoride in the background, the ones with no fluoride in the background, you get a 33% estimate of prevented fraction, which means a third less cavities just by putting povidone-iodine on. That's impressive. That's exciting. we don't have many things like that. And I'll say this is actually cavities overall. This is not the number of teeth with cavities. This is not DMFT or DMFS. This is kids with cavities. Fluoride varnish doesn't do this. Silver diamine fluoride seems to do this, but we don't have a lot of interventions that actually reduce the number of people who get cavities. So this is profound, and that's why I'm spending all this time talking about it. Now, what else can we learn from these studies? So what if we mapped out the frequency of application to the prevented fraction and ask, is there a relationship between the application frequency and the preventive fraction? And so what you see here is how many applications do you have per year in these studies, and what's the outcome of the preventive fraction? I probably don't need to draw a line for you. You probably see this relationship with your eyes. By the way, the size of the circles represents the size, how many patients were in the trial, therefore the power. And that's pretty convincing. Now, to get a real yes there, what we need is actually a comparative trial where we say, okay, 6 applications per year, 12 applications per year versus 3 versus 0, or whatever you'd like, to really see, is there a dose effect? But this would suggest that there is a strong dose effect, and the more frequently we put it on within safety, the better the effect. We'll get back to safety later, but you can put this on pretty frequently. So to get that frequency, don't you think people might be wanting to do that at home? Do I want to go into the dental team 6 times a year? I don't. Do I want to bring my kids in that often? I don't. Do I want to brush their teeth like I do, every night, and put something else besides fluoride toothpaste on every now and then? I could do that. Perio. So the question has come up about perio. I'm a pediatric dentist. I'm going to be expanding my practice to look at all ages, which is lawful in California. So I've been interested in perio, and this has come up a lot. I should say that there's a group at University of Southern California that spent, I don't know, decades working on povidone-iodine with perio. And they've shown over and over again that in the lab, in patients, povidone-iodine kills periodontal pathogens. There's a question about what's the long-term effects, and how long does it take for these bacteria to come back? But if you're interested in that, go look up Jorgen Slots. That's Jorgen Slots. He's had a whole career on perio, and there's a lot of iodine stuff in there. And then Anna Fuchs did a lot of work there also. That said, you know me, I like clinical trials and forest plots. And so there are, here there's 8, but there's more, but there's 8 high quality clinical trials on the question of using povidone-iodine in scaling and root planing irrigation. Now that 10% is a bit of a misnomer. Some of these studies used 1%, some used 7.5%, but does just a one-time scaling and root planing where the irrigation liquid, cooling liquid, is povidone-iodine, does that have a long-term effect, 6 months, a year, 2 years, on periodontal outcomes? And the answer is unfortunately probably not. I had heard a lot about this from Dr. Slots and Dr. Fuchs and periodontists all over, dental hygienists all over the country, that they use povidone-iodine because maybe it'll help. Now, there is a trend on all measures. If you look at bleeding on probing and inflammation and pocket depth and clinical attachment loss, there's a trend where it looks more helpful for this one-time encounter, but it's not statistically significant across these trials. All of these are one application. What did we learn with caries? So this makes me wonder what would happen if you did it more frequently. What would happen if you had people apply it at home as a supplement, or come in every 3 months or whatever you like. From what I have seen, there are not clinical trials on that. At least they're not incorporated here. You may have noticed that what just popped up also is that the bleach, hypochlorite, does seem to have an effect. So this same meta-analysis here also looked at whether the same question asked with putting dilute bleach in your scaling and root planing irrigation, in your ultrasonic irrigation, Does that have a long-term effect on perio health? And that does, especially if we look at the gold standard outcome of clinical attachment level. So what would I do with that? Well, I would very carefully dilute and have one person in the practice who is responsible for appropriately diluting hypochlorite in my trough, in my irrigation trough. Make sure that patients can tolerate it. I would go lower because bleach tastes bad. I would go to the 0.1, not the 0.5 for me. And then I would have patients apply povidone-iodine at home. That's what I would do. Are there clinical trial? Is there clinical trial evidence to support the latter? Not yet, but we should try. So all of you looking for research projects, it's out there. Now, what if we ask the question about peri-implantitis? Now, there are subtle differences in the microbiota, the bacterial profile on an implant versus a tooth with perio disease. And here, there are 3 studies I was able to find. They're all relatively recent, all of which showed an effect of povidone-iodine. Here you have very dilute povidone-iodine versus full strength, and even the 2% one time with scaling and root planing, obviously very carefully hand scaling around the implant, showed a dramatically improved effect compared to the lower concentration, which they assume is not effective. So scaling root planing improved their pocket depth. They didn't do clinical attachment loss, but you got an even bigger effect with the higher concentrations. So that was exciting. It's one clinical trial. Is that right? I don't know. But in reviews, the reviews like Stein here and J. Perio say that povidone-iodine is used in standard peri-implantitis protocols, seems to help. And there's another trial that looked and saw a dose-dependent reduction in gingival inflammation and bleeding. The trial wasn't long enough to look at clinical attachment loss or pocket depth, but all of the signals are that this helps peri-implantitis, and I see no harm or risk in trying that. And that said, why aren't we trying with more frequent application? You know, there's been these clinical microbiology for decades and decades and half a century. Why aren't we trying more frequent application? One of the reasons is that people don't trust patients to do this at home. The researchers, the researchers should and do isolate the variables, so they want to do it. They want to do it. But if we empower our patients to do it, if we empower even in the studies for people to do it, maybe we'll start seeing a bigger effect. It certainly suggests, the data suggests this will be the case. So no strong evidence in favor of using povidone-iodine in your irrigation, in your ultrasonic irrigation. There's a trend that it's helpful, certainly doesn't hurt, but it does seem to help with peri-implantitis, and there is what I see as evidence of suggestion that if we apply povidone-iodine more frequently, like having patients use it at home once a month to suppress bad bacteria, then perhaps we will get better perio outcomes. Okay, you can see I'm passionate about this stuff. Now we're going into anti-caries mechanisms. So this is I spent 5.5 years as a postdoc in one of the labs that created omics, genomics, microbiome, all that stuff, studying caries bacteria. It's incredibly complex. You know, you take a sample from here and here on the same patient in the same day, they look really different. You take a sample from here and then a week later from here, same patient, they look really different. So it's hard to tease out a really good signal from anything that we do when we're looking at every single bacteria in the mouth and the yeasts and all of that. But this study was interesting to me. So what they did here was they looked at the effect of povidone-iodine on the microbiome, and they used some statistical tricks to say, you know, this pattern, this prominent pattern versus that prominent pattern, can we separate these guys out a little bit? And so they looked pre-iodine, caries active, that's the blue circles, and caries free, that's the white triangles. That's what they look like. Does iodine shift these circle people from caries microbiota to a more healthy, a more caries-free like microbiota? And the answer appears to be yes. So if you look here, the blue versus the white, here you have the brown as the post-iodine. I'll keep going back and forth. Is this a perfect metric? Is this a perfect outcome? Take note of both of those questions, but I see more brown where the white is than the blue. So perhaps this is a signal that things are working and that we're not ruining people's microbiota. So stuff is complex and subtle. Now back to this. We talked about this earlier, Paige Caulfield and Gibbons work on taking plaque samples before and after strep mutans. Because the question came up, like, why do we use this? So how do we know how frequently to use povidone-iodine? And here's a plot of this outcome. I look at numbers and I don't understand. I look at images and I understand. I'm a visual person, as many of you dental folks are, but this is over time, where 0 is when the povidone-iodine is placed. And this is the fraction of it's how much strep mutans they see compared to the baseline, and everything's normalized to 100% at the beginning. And then what you see is that occlusal strep mutans comes back. And if I show the error bars, they'd be all white. So this is basically the same as baseline. The occlusal, it comes back, but even after 2 months, it's still a quarter, a third of what it was at the start. The saliva and the floss area, proximal strep mutans, actually stay suppressed even when they're looking at 20, 24 weeks, which is very exciting, very interesting. But the bacteria do come back. And so this is part of the idea, is that if this is the trajectory and in particular occlusal caries are such a problem, maybe we should apply and keep applying and suppress the strep mutans from being able to come back and cause problems again. Note that proximal surfaces are smooth surfaces, and actually one of the things that was observed in the rat trials over and over again was that you had a bigger effect on smooth surfaces, and look, the strep mutans is staying lower on these smooth surfaces than on the occlusal. Had an effect on preventing caries in rats on the occlusals, but a bigger effect on the smooth surfaces, and this seems to match that. But again, we use this to inform our protocols. So how frequently do we put it on? For someone with no caries risk, with a mild caries risk, low caries risk, they don't need this stuff. Why would they? They're healthy, don't mess it up. But what we learned from plotting here is that the more frequently you put it on, it seems like the more of an effect we have on preventing caries. So the clinical trials have generally done 4 to 6 times per year, every 3 to 6 months. Every 2 to 4 months, 4 to 6 times per year. What happens if we do it more often? Somebody has more risk or they're motivated. Yeah, absolutely. We'll talk about safety in a little bit. And my argument, which is why I'm so grateful that Elevate made this product, this kit, is that this has got to be done at home. Or you can send a person to a school or something, Head Start, with a lot of frequency, but that's rough. It's a lot of work. And if we expect people to brush their teeth, why can't they do this? Okay. Now, as I talked about in the last webinar, I just want to restate this. A couple years before the pandemic, it's a bit of a long story. I'll skip the long part of it, but basically two nurse moms came to me and said, I heard that iodine can be used to treat caries, which then, which I'd never heard of, and it's not in the literature anywhere. But I did a deep dive and came up with a protocol of using it 1 week a month based on the really intense suppression at a week, and saying if we put on povidone-iodine, a week later the strep mutans is going to be really low. If we put it on again, it's going to be even lower. If we put it on again, it's going to be even lower. If we put it on again, maybe then we've overcome the infection and allowed other bacteria that aren't as sensitive to grow. Now, I don't want to have people do it once a week forever. It's a lot. So then can we slow things down? So we have a therapeutic course, just like we do with antibiotics. Sometimes you do multiple antibiotics or a double dose of antibiotics at the start. And then you have a maintenance phase. So the therapeutic phase is once a week for a month. The maintenance phase is once a month, or the caries are really bad, twice a month after that. And I did this with 23 patients, and I got a great effect where I motivated the family to do this. It was anterior, where they had said no to silver diamine fluoride due to the stain, all primary teeth. And we got caries arrest, as you can see. These are some images where you can see the arrested lesions. Kids were, in general, pretty young. There was a couple older kids, 6, I think was the oldest, 5 or 6. But we got a much better response than what I would expect from just toothbrushing. Not all of them use fluoride. There's quite a lot of anti-fluoride people where I was working. And even some of the cavitated lesions arrested, like these lesions. Initially, they weren't broken out to the lingual, and then they did, which made them cleansable. So was this an artifact? I don't think so. They're amber, they're hard, they stopped. So this protocol should be tested, seems to work. There's a whole lot of information about anti-caries mechanisms that was in our previous episode. And I want to zero in really on the relationship with fluoride. So this is from a study that was published in Caries Research the year I was born. If you see this this beard, that was a long time ago. But what they did is they took rats and they gave them a bunch of sugar and strep mutans, and then they gave them either water, or a different group got fluoride, different group got iodine, different group got both. What we see in the color scheme here is these are enamel lesions. This is at the DEJ. This is into the middle third of the dentin, and this is buccal and sulcal. So buccal is basic for rats. It's like a occlusal, and sulcal is like a smooth surface. And what you see is you have a dramatic effect that's bigger when you're adding the iodine and the fluoride together. So you see less red down here than even here. Obviously, fluoride prevents compared to up here. Iodine prevents compared to up here. But the bottom row shows that they are at least additive. And when you look at the effects here, what you see is you don't, I think I said it backwards. Buccal is smooth surface, sulcal is occlusal. My apologies. Buccal is smooth surface, sulcal is occlusal. Apologies on that. What you see here is you have a greater additive effect on smooth surfaces, that's on the left, thank you, and synergistic effect in fissures, and pits and fissures, that's like occlusals. So what we see is you have more effect than you would expect. Basically, iodine on its own did not work on the occlusals in rats. We're not rats, but in rats, you get a bigger effect than you would expect. Basically, they work together. They work independently in humans, thankfully, not in rats. They work on smooth surfaces in rats, both of them. But there's evidence that they can work together. It's very interesting that it didn't work in the fissures, in the pits and fissures of rats, to prevent caries there. Well, it did prevent deeper lesions. Iodine didn't, but when you added it with fluoride, it was greater than the effect of the fluoride alone, showing that they actually have some kind of synergistic relationship. I would guess that it's probably tapping into the antimicrobial mechanisms of fluoride, where, if you've forgotten, fluoride has effects on slowing the growth of bacteria, preventing sugar uptake, and therefore acid production. All that said, what's the point of this? Why am I focusing on this today? Well, we have an increasing anti-fluoride group, or fluoride hesitant, or people who say no to fluoride, 3 different things. And iodine's an option for both of these groups. It's one of the things I love about it. I, obviously use a ton of fluoride for my kids, for myself, for my family, for, my patients. But there's a large portion of people who aren't comfortable with that anymore, or want alternatives. This works for both camps. Okay. Safety trial. So, safety profile. Again, I want to go back to this piece. Thank you, Elevate. Now, what are we using it for? Is this an off-label use, like so many of it, like fluoride varnish? No, we're using it as an antiseptic on oral tissues. This is on label. This is not an off-label use. This is we're killing bacteria, we're killing microbes, yeast, in the mouth. This is on-label use from my perspective. Now, if we're trying to use this, can Elevate go and say this is anti-caries, anti-perio, all that stuff? That's a different story, but this is on-label use. Okay, let's talk about contraindications. If someone says they are allergic to iodine, don't put iodine in their body. It's incredibly rare. There's some people that have contact sensitivity, some people who have reactivity. You know, review it. Did they have a reaction to having iodine injected into their blood for, you know, as a contrast agent for some sort of fancy radiography or chest X-ray or whatever? Have they ever used Benadryl? Sorry, have they ever used betadine on a wound? Any problem there? Would be the follow-up question. We said silver allergy should be a contraindication for SDF, but I have yet to find anybody with a silver allergy. Most people, if they say that, they just say, "Oh, do you mean nickel?" "Oh yeah, I'm allergic to the nickel that's in a lot of silver." Okay, so kind of the same thing here. They exist, but they're very rare, iodine allergies. But if someone says they have an allergy, if extreme sensitivity, then obviously do something else. Of course, you can consult with their physician if you really want to. The reactions, the allergies that people get to iodine are actually very mild and usually just handled with Benadryl. So this is not a anaphylactic situation. Do not give it to people with beta thalassemia major. That's a specific blood cancer. They seem to be incredibly sensitive to iodine for some reason. You will know if they have beta thalassemia major. There will be no question. You will be seeing them in the hospital, unfortunately. So this is not something that you will miss on the medical history. People with advanced thyroid disease, with severe, so a lot of people have advanced thyroid disease. Very few of them also have severe iodine intake sensitivity. They will know. So just say iodine. If they say not for me, then great. Now, one of the first things that was discovered about intraoral use of iodine was that you should not put it in a wound, like in a deep wound. An abrasion's no problem. You know, you want to clean up an abrasion. It's dirty in the mouth. That's no problem. But a couple of oral surgeons thought it would be a good idea to take a third molar extraction, wisdom tooth extraction site, and put povidone-iodine into there and then suture it up. So they like literally have a bolus. That did not turn out well. It was very irritating to go back and clean things up. But they were trying to prevent infection. So don't do that. Don't like put a bunch of the liquid into a wound and then suture it up. It's the same thing, like you don't put it under a Band-Aid and then like seal the Band-Aid up because that can be irritating. You would just use it as an antiseptic, let it dry, and then put that over. That's no problem. Same thing in the mouth. You just let it dry. And again, the connection to seafood allergy is like one of the classic medical myths. So that's bogus. So again, basically, if someone says like, I have a problem with iodine, ask follow-up questions. If they have a serious blood cancer, you're seeing them in the hospital, it's called beta thalassemia major, don't use it. If they have severe iodine intake sensitivity, again, already covered here, but that can happen with advanced thyroid disease, you know, don't use it. And basically everybody else seems to be good. Why? Because it is a necessary nutrient for life. If you don't, you get this thing up on the right. If you don't have iodine, you get goiter. So you need iodine to live. There's all sorts of molecular mechanisms of why we need this for proper thyroid function and homeostasis. And if you want to take a screenshot and dive into the dosages, there's this thing called no adverse observable effect level, upper tolerance, upper level of dosage for everyday use. And basically the dose of an iodine application every day falls within this for 9-year-olds and up. So this is what we're talking about here is very, very safe. It's within the normal recommended amount. It's lower than if you have some sushi. If you have a piece of seaweed, there's usually more iodine in it than what we're talking about. So this is required for life and generally very safe. You would have to down a bottle of iodine to have the acute reaction. That could be a problem. So don't drink it, but put it on your teeth. So again, in summary, it's an essential nutrient. Allergies overstated. Just use diphenhydramine, Benadryl. Seafood allergy is a myth. There's plenty of safety studies. It's the gold standard for people with cancer who are getting mucositis as a prevention and a treatment, although it seems like xylitol might be even better. It's commonly used as a perio ultrasonic scalar irrigant. That one-time use doesn't seem to have a dramatic effect, but certainly doesn't cause any harm to people. and there's no reports of contact dermatitis ever from intraoral use. So that was the fun part. I'm going to get into some Q and R, question and response, hopefully provide answers now. And thank you everyone for submitting questions. In particular, my good friend and birthday buddy, Gretchen Child, for collecting many of these questions. So here's this question that comes up for some of the Elevate folks, for a lot of clinicians out there, and patients most importantly, does antibiotic resistance occur with povidone-iodine? And so read the title of the paper, Absence of Bacterial Resistance. So in this study, they used 7 different species that typically generate resistance, that are bacteria that like to generate resistance to things. They did this serial passages. It's a microbiology technique where you basically grow the bacteria almost killing everything, and you try to generate a resistant strain, and they couldn't do it. Despite 20 tries with 7 species, nothing generated. So they were these serious medical microbiology people at a serious hospital said it's not there. But then, so that was 1976. Then 25 years later, 3 years later, another group said that's not good enough. And so they tried 693 strains, lab strains, 472 fresh clinical isolates, including many antibiotic resistance strains, and did a whole bunch of dilutions and plated everything out, and did the serial passages, and nothing. So they concluded that antibiotic resistance does not affect the utility of chlorhexidine or povidone-iodine as antiseptic agents. That's why these are the 2 most commonly used antiseptics in the world. Anyway, they are. So the answer is no, we don't have resistance. Sweet. Why? I made this picture famous in the dental world, talking about silver, and that silver ion is a wrecking ball. Well, the iodine ion is a wrecking ball too. Again, it deactivates pretty much all proteins, all of the side chain rings, deactivates them. It deactivates DNA, it deactivates RNA, and it can do a similar thing with the lipid bilayer to open it up. So it's indirect. It basically acts on the proteins that are in the lipid bilayer, but then it ends up opening the cell wall of the bacteria. Why every 1 to 2 months? So we hit this earlier, but for review, we have strong suppression of strep mutans for 2 months, and then it starts to go up, especially on the occlusal. So we want to keep the bacteria down. So the more frequently we put it on, the more we're going to suppress the strep mutans, stop it from doing what it so direly wants to do. Put it on a leash, tame it. A higher frequency is recommended to achieve, higher recommended, yeah, I don't know what I was trying to say there. But if people have worse disease, use it more frequently. Can you seal povidone-iodine treated teeth? Luckily enough, somebody did a bond strength study with resin, and there's actually, in this study, there's a statistically significant effect where you get a higher bond strength with povidone-iodine than just the control, but whatever. And actually, sorry, it was you put iodine first and then etch. I'm guessing that's just noise from the study, because they did povidone-iodine then etch, and they did etch then povidone-iodine. That was different, so who knows? But they did etch and then povidone-iodine and then the bond, the resin, and that still worked just fine. So it's all good. Yeah, it's all good. It all works. No problem on bond strength. Can you bond? So that was enamel for a sealant. Can you bond iodine-treated dentin? And this is a study where they looked out 2 months. It's in the lab, but they bonked it a bunch of times and put it in hot and cold water and all that stuff. And again, the answer is yes. And the reason they were interested in this, and actually you had better maintenance of bond strength than the control, or even than chlorhexidine. And the reason they looked into this, which I didn't even know before I found these studies, is that it's actually well established that povidone-iodine inhibits matrix metalloproteinases. So if you don't remember what matrix metalloproteinases are, they digest the proteins that help to support the dentin and bone also, but they digest proteins associated with bone or dentin. They're naturally in the dentin, and when dentin gets demineralized, they get activated. They get activated to go destroy the protein, so that the tooth can do what it can to keep the bacteria out and not live off the protein and so on. But it deactivates those, so you maintain, and then you can of course remineralize if you still have your scaffold. So it's a good thing if we are treating the teeth to inhibit the MMPs, and povidone-iodine does that, thus preserving bond strength, which is cool. What CDT code should I use? Well, that's up to every clinician. What makes the most sense to me is the D1355. That's caries prevention with a medicament. Povidone-iodine is a medicament. This is usually what we're going to do. Does it make sense to use the 4381 localized delivery of antimicrobial agents via controlled release vehicle? Technically, povidone is a controlled release vehicle, but I do not think that was the intent of this code. I think that's describing more like a chlorhexidine or minocycline slow release, as in slow over the course of weeks or months, whereas povidone-iodine just holds onto the iodine until it's dilute, saliva hits it, it goes. So I would think it should be D1355, and then if you're distributing it for use at home, to me that's 9630. So if someone had high caries risk, I'm applying povidone-iodine maybe to exposed root surfaces in an older adult. I would do D1355 for each surface that I apply it to that day, or my staff applies it to that day. And then if I distribute to give it to them at home, then I would do 9630 to codify that. That is all for today. I want to say we've talked about sort of the origin story, and again, thank you Elevate for releasing this, for making this, for doing all the work. We talked about the mechanism. We reviewed. Again, there's another webinar that's on YouTube. You can get free CEs for, just answer a few questions. Should be easy. We talked about the caries trials and what they teach us. In particular, I think the lesson is it works and it needs to continue being applied multiple times per year. We talked about perio, and perio, it seems like it might actually really work significantly for peri-implantitis. It seems like one time only doesn't seem to have enough of an effect for periodontal disease. There's a trend, so maybe we should try more frequently. We talked about anti-caries mechanisms, so it works with or without fluoride. That's the big take home, is it works with or without fluoride, making fluoride more effective, in particular in pits and fissures, but also working on smooth surfaces. The main mechanism is that it suppresses the cariogenic bacteria, but it also specifically suppresses plaque formation from glucosal transferase. And it does that in a way that no other product seems to be as effective at doing. It's incredibly safe. Iodine is required for life. Putting this on every day, there's no reason for us to do that, but it does have less iodine usually than like a sheet of seaweed. So once a week for a month shouldn't be a problem. Once a month shouldn't be a problem, except for very rare cases. Doesn't seem to affect bond strength, and it does not generate resistance. Now we'll go to live questions after I just say this one last thing, and that is that if you're in the San Francisco Bay Area, please reach out to me, and you're all welcome to reach out to me anytime with observations, ideas, questions, comments, all of it. Here's my newer email now that I'm Jeremy Horstkeeper. So thank you very much, and turn to questions.
Well, thank you for that, Dr. Keeper. That was a wonderful course. You provided so much great information, so thank you for that. I want to start with that. And we've had a lot of conversation in the chat and some wonderful questions come in. So I'm going to send a couple your way. Some of them, it's almost like you knew what was going to be asked. It's so similar to some of the questions that were coming in, and when you kind of went through those Q&R, you addressed a lot of things. So that was wonderful. One of the questions that came up a couple of times was, what is iodine effect on the oral microbiome does it kill healthy and unhealthy bacteria? So would you mind just addressing that one? And it was also kind of stated that, you know, if there's hesitancy in incorporating povidone-iodine because of its potential negative effect on good bacteria, could you just cover that for us a little bit more?
Yeah, thank you so much, Brooke. And I had to run to a different room real quick, but thank you again, everyone. In terms of the effect of on good and bad bacteria, the studies in the mouth are all very encouraging. Like the microbiome shift that I showed you, it seems to be shifting, allowing a shift for the bugs to get into a more healthy state. There's been some questions about how this affects periodontal pathogens, and that has been a subtlety of bacteriology, where if you put any of the bacteria in solution, that we call it the planktonic state, in a liquid, it'll kill all of them. If you grow a plaque with them, like on top of a petri dish, at different concentrations, some bugs still grow at, depending if you just put a little iodine or a lot, and so on. So there's some subtlety there, but ultimately what we see is the clinical studies show suppression of the bad bugs. And that's what we're really after. In terms of the rest of the microbiome, I did look up whether there was any studies of the effect on the gut or other microbiomes, and I didn't find anything useful. Applying in the mouth, does that affect anywhere else? I didn't find anything useful. It turns out lactobacilli are particularly sensitive, just like strep mutans, and the role of lactobacillus in causing cavities has been established for a long time. So in the mouth, that's helpful. But there is some stuff out there about trying to use an antiseptic to potentially control Staph aureus or strep B and other potentially harmful bugs during birth. And it turns out that's not a good idea. So there's some really good studies where they looked C-section, vaginal delivery, with or without povidone-iodine applied to the vulva, and the microbiome, the lactobacillus, don't appear on the baby as much, and it is thought that in general those bugs should go. So I'm not an obstetrician. I'm not going to comment any further on that, but as far as we can tell, it seems to suppress the bugs that are bad in the mouth. It seems to do a good job of suppressing P. gingivalis and actinomyces in the mouth, actinomycomatans, whatever that word is. But in the petri dish, things behave odd.
Okay. Thank you for addressing that. And then you touched on this already, so I think that you may have already answered this. One of the questions was just around the protocol. That, you know, we do see so many different protocols out there. Looking at the protocol for povidone-iodine, but you addressed that, I believe. But if you just want to answer that one more time.
Yeah, I mean, I think, you know, do what makes sense to you. So we try to show you the data and have you make your decisions about what's best for your individual patients, for the population you choose. Certainly, like I showed, it appears that there is a relationship with the frequency of iodine and the effect on caries. So what do I do with that? You know, again, it depends on the situation. What's practical for this person? Is it a really motivated person or parent who can do this on their own? Then we start asking these questions about how reliable is their self-application. Now, if you ask me to do something once every 2 months or every 3 months, I might lose it. I won't get mad. I just might forget to do it. And so if you ask me to do it once a month, I'll put that on my calendar once a month. That's easy. So that's where some of the logic comes from, is the practical aspect of performing these things with the hope that it'll be even more effective, and assurance from tons of safety data. There's safety data, like I said, of people doing this every day for 6 months. So I think that's where there's variance in the protocol recommendations. And then there's a difference between prevention and treatment, where for prevention, we don't need to do things as frequently as what I've been exploring with doing this for treatment.
That's great.
Hopefully that helps.
It does. Yes, thank you for that. And then the last question here, so we had questions around safety, but you've addressed all of that. So I think that we've covered that. The last question, and we'll close with this one, is are you able to use povidone-iodine and hydrogen peroxide sequentially, or should they be separated?
Whoa, that's some good chemistry. That'd be fun. I don't think I've ever. We were playing around with destaining silver fluoride from after it had set into teeth, and it it bubbles up. Peroxide makes things bubble. I would choose one or the other. I don't think there's a rationale for using both. Personally, like in the pandemic, when things were really bad with the virus, people were using one or the other as a rinse before dental treatments, dental interventions. That's a good one. I'm gonna have to say I don't know whether you want to use it before, what order. I would assume that you would just use one or the other. Peroxide rinses off really well. It does not have substantivity, so feeling like I need to provide some kind of a guess, I would do peroxide first if you're doing it for whatever reason, and then rinse it off and then apply the povidone-iodine. Part of the effectiveness of povidone-iodine is that it does have some substantivity, some stickiness. So I guess I would want that to stay on. There we go. That's my answer. It's my final answer. Peroxide first, rinse, then iodine.
I like it. I like it. We'll close on that. Thank you so much for your time tonight, Dr. Keeper, and sharing all of this wonderful information with us. We really appreciate that. It's a wonderful CE. And to all of our attendees, thank you so much for joining and spending your Tuesday evening with us.